Thank you, Dr. Koizumi, and thank you to the Japanese Primary Care Association for inviting me. I'm truly honored to be here today. I promise not to keep you too long, but let me do my duty. I am a family physician. I'm trained under the same program as Dr. Lee. Singapore is known for many things, and one of the most popular icon used to be the Merlion that is gracing the waterfront. And however, because of economic reasons, we've built a bigger icon, which is now the integrated resort, or the Marina Bay Sands Casino. And but actually, the real secret to Singapore's success and as a tourism area is actually the chili crab. You know? The most delicious food you can find in Singapore if you don't splatter it all over your chest. And the chili crab can actually be bought at the seafood center, which is at the East Coast, where you coming from the airport towards the city, you will pass it on the left-hand side. And there's another pass that actually goes under the expressway, which will lead you then into my clinic. So I practice at a suburb as a solo practitioner for the last 18 years as a solo family physician. And this is a picture of, let me see if I can, picture of my clinic. I named it after my late father, Kang Hui Si Yao Fang. This is my waiting area, and tucked at the end is my broken down ultrasound machine. So I'm very happy to hear that the Koreans actually provide ultrasound services in primary care. I truly believe that it is very useful. In fact, now in the A&E accident emergency, a lot of hospitals, ER departments are beginning to use ultrasound, which is actually very effective. And I'll explain a little bit more what Singapore did to promote ultrasound in primary care. As an introduction, I've undergone the proper formalized family medicine training program, which is a 3-year period from 1991 to 1993, so I think you can guess how old I am. I must thank Professor Goli Gan, who is a good friend of Professor Kasai, for starting this program. We went through rotations. I went through actually about 10 departments: obstetrics, gynecology, pediatrics, internal medicine, including the ICU, general surgery, including surgical ICU, orthopedics, hand surgery, psychiatry, sports medicine when I was in the army, community or government primary care centers that we call polyclinics. Did a 3 months rotation in dermatology, infectious disease, as well as STD, sexually transmitted disease. And I did 3 months in otolaryngology, or ear, nose, and throat. And this is a picture of the nasopharyngoscope, which I use very often for the past 18 years, ever since I left the Department of ENT. A very useful little device. I sat for the following exams, the diplomate exams of the College of Family Physicians in 1992, which became obsolete or defunct when we started the Master of Medicine in Family Medicine. In 1993, I went on to do a diploma in dermatology in the University of Wales in Cardiff, UK. And as it was not enough, I went on to do a Master's of Business Administration, or MBA, also in UK. And because we felt that ultrasound was quite useful, the then President, Alfred Lowe, and together with the late and great Prof. S.S. Ratnam of NUH, got together and decided to start the graduate diploma in basic ultrasonography in obstetrics and gynecology in the National University of Singapore. I was then appointed as the chief examiner and course director. If anyone wishes to know a little bit more about how to start a course like this, let me know. And I was also the former chief editor of the Singapore College of Family Physician. And lastly, my other love for medicine is actually in medical law. I was last with a Medical Protection Society, which is the world's largest doctors' mutual indemnity, which covers, I think by now, more than 300,000 doctors worldwide. And I took about 5 calls a day, which is about, must have taken about 10,000 calls over the last 10 years. So strategies to promote family medicine in Singapore. I'd like to quote our former Minister of Health when he says that when a patient can be adequately treated by a GP but is instead managed by a specialist in tertiary hospital, it implies a waste and abuse of expertise, a waste at the expense of a seriously ill person who requires the expertise of a specialist. That was in 2006. I would like to cover the three topics of the problems currently: quality issues, which was my thesis for my MBA, and system changes. We all know about long working hours. All doctors like to work long hours. It's one of our biggest problems leading to burnout among doctors, affecting our marriages and our relationship with our children and our health. Solo practice is no longer popular all around the world, so it's the same in Singapore. We tend to move towards group practices. Aesthetic practice is increasingly more attractive to the young ones. It's more lucrative, makes more money, no evening clinics, and in fact I was just talking to a young medical student over there that she should think about aesthetic. Lack of appointment system is a problem among the private GPs. Manpower shortages in government primary care is another issue. I'll cover this in slightly more detail. So a lack of appointment system actually would lead a doctor to hurry. And if a doctor hurries, he cannot maintain standards. Standards in waiting time, professionalism, a comforting and soft speaking attitude, allowing time to ask questions and clarify doubts and fears, a gentle mannerism, politeness, and courtesy. You'd be surprised how many doctors do not feel that courtesy is an important aspect of medical practice. They feel that they are on top of the food chain and the patient is below. There is a shortage of Singapore-trained doctors, as I understand it is in Japan. However, there's a cultural transition that all overseas doctors have to make, and they fail to make that because they lack language skills in Mandarin, local Chinese dialects, which is about 4 or 5. There's Hokkien, Cantonese, Teochew, Hakka, Fuchao, 5 or 6. I speak 2 dialects, and I speak Mandarin. I speak quite good Malay, but I don't speak Indian. So many of our poor patients cannot speak English, and this language barrier has caused communication problems and a lack of trust in overseas doctors. And most local family physicians can speak most of the languages, including English. English is actually mainly our first language, unofficially. Quality in family medicine. I'm going to cover the next few areas. The Kazan report, which we all know about, not too much detail. What's the definition of quality? It's a very nebulous term. Everyone bandies it around, and it's like the elephant. Someone touched the tail, and someone touched the tail, we call it a rope. Someone touched the legs and call it a trunk, and then someone touched the body and calls it a wall. So what is quality? I'm going to say that there are 2 types, and then I'm going to talk about family physician register, which was a big move in Singapore, and how we're going to achieve this thing called quality. This is taken from the Kazan report, so I'm not going to go through too much, except to emphasize that from the current approach to the new rule, information is no longer just a record. Information is a knowledge which is to be shared, and it should belong to the patient and not to the medical institution. So electronic medical records should be the way to go. In Singapore, we haven't really implemented it. There are lots of different platforms, and we have difficulties trying to migrate one to the other, and to get a cooperation of different stakeholders is not that easy. I'll move on. How do I define quality? Quality to me actually should be defined by the customer, the person who consumes the services, and not by the provider. So it should result in the following areas, and it should be a continuous process. I think the Japanese calls it Kaizen. Am I right? Yeah, okay. So it wasn't invented by Edward Deming. It was actually, quality was invented by the Japanese. So it should result in patient satisfaction, in disease management, in prevention, such as PAP, smears, vaccinations, in disease outcome management, such as HbA1c, lipid levels, pain control, BP levels. It should reduce wastage and inefficiencies. Actually, in MBA, we learned that there's a Sugino pond. A Sugino pond is a Japanese concept. If you look at the surface of a pond, it looks all right, it's clear. But if you drain the pond, and then you see all the rubbish that's in there, a lot of times, all systems looks very good on the surface. You go visit the hospital, it looks nice. But you don't see the problem, you don't see the inefficiencies, and you don't see the wastage. Very much like trying to date a girl or a guy. The first date is always very nice, and then later on you find out the problems. sometimes only after marriage. Don't tell my wife. And lastly, of course, to reduce overall, the big C word, cost, because it's a problem everywhere, right? The Obamacare now is all about cost. Every government official that talks to you has got money on their mind. It's about money, it's about taxation, about taxpayers' money. And the patient that walks into your clinic actually wants to know how much he's going to pay out of his pocket. In Singapore, we have this thing called MediSave, which is actually a pension fund that belongs to the patient. So he pays it either by cash or he pays it from his pension fund. And if you live long enough, you're going to run out of all these things. Just like you're going to develop cataract and mild dementia if you live long enough. And the same thing, your money's going to run out. So the older the population is, the more the society ages and grays. And like Professor Lee Kim Hyo said, it's going to be a huge silver tsunami that's going to hit us all, the developed countries. So a lot of countries have actually resort to the stealing talent and brain from other countries. But that is wrong, because you're actually depriving, for instance, we deprive India of their doctors and their nurses, or Philippines of their nurses. UK is doing that. UK is taking nurses from Philippines and India, which is wrong. You should send them back. You should train your own people. Now Japan, I think, is doing the right thing. Japan has only taken about 200 nurses from Indonesia and Philippines over the last so many years, you know. And they're doing their own good thing, but the rest of us, we're just doing the quick thing, the transplanted thing, which I think is not sustainable, because healthcare is very culture-based. Enough of that. Who benefits then for quality improvements in primary healthcare? This is very important, because you want to know who are your customers, who's going to pay for all these quality initiatives you're going to do. It's very nice to talk about it, but who's going to pay? And who's going to benefit? And I can think of these few people: the people of the nation, in this case Singapore, the families of the elderly and chronic sick, corporations and employers, workers, and of course insurance companies would love to see higher quality but less care. Faster, cheaper, better. Can you achieve that? It's always difficult. You can achieve one or two, but not three. And to me, quality comes in two types. One is technical quality, the other is service quality. My MBA thesis was on service quality. Technical quality is something that actually all customers assume that you have. If you fly an aeroplane, be it SIA, be it British Airways, Qantas Airlines, Japan Airlines, you assume that everything is going to go safely. You assume the takeoff is going to be smooth. You assume you don't even want to watch the safety video telling you to put this on and put it on and blow the whistle. You think that you're going to land safely, and you take it for granted it's going to be safe. Now, then you fly budget airways and you hear about Ryanair giving problem. You hear about Lion Air in Indonesia crashing and all that. But you still fly an aeroplane and presume that it's going to be safe. So when a patient sees a doctor, if the patient doesn't know what's a family doctor, the patient doesn't know family medicine. I have the family medicine clinic name hanging out there for the last 18 years. Nobody asked me what is family medicine. So are we deluding ourselves about talking about family medicine? I myself just put my name up there, you know. I'll call it the chili crab clinic. You know. Now, technical quality is something that patients assume that you have. They don't distinguish between this and that and other. It's a clinic, he's going to go in, he's going to pay this much, he's going to get out of there. The service quality aspect is what the patient actually wants. He wants to see you when he needs to see you. He doesn't care if it's a Sunday, he doesn't care if you're having a dinner with your family, he wants you to be accessible. Preferably 24 hours a day, 7 days a week. He wants it to be cheap cost. He wants it to be affordable according to his price. He doesn't want to wait. He expects you to be professional, and he expects you to have a good attitude and courtesy, even if you're hungry or you have a child who's sick, or in my case, my father-in-law was very ill and died recently. He doesn't really want to know that you have problems. Unfortunately, many clinics and GP clinics tend to be old, small spaces, understaffed. This is in Singapore, not in the UK and Australia. And poor air conditioning, sometimes it leaks, my aircon leaks. It's cluttered with posters. It's located next to a noisy road like my clinic. There's poor access to laboratory services, such as X-ray and blood tests, which is so important now because everything is moving towards more and more technology-based diagnosis and diagnostic tests and diagnostic modalities. We're beginning to order more and more ultrasounds and Ultrasounds, I do it myself, but the blood test and all that, you still have to outsource it. So one of the things that the college fought for and managed to obtain, one of the rare victories, and it all actually goes to the work of Professor Lee and all his team as counsel, was the Family Physician Register, the FP Register. After so many years, tracing back the history from when Professor Goligan and his gang and Alfred Lowe organized the Wonka and got the government to recognize family medicine and finally set up the exams. Family medicine has been recognized as a discipline of its own by the government of Singapore. And the register was initiated by the college, accepted by the Ministry of Health in 2011. It has placed family medicine as one of the recognized disciplines in medicine in Singapore. We do not call ourselves specialists. We want to use the term generalist. It's a euphemism. It's up to you to fight over the term, but basically we are quite aware of what is the work that we do. So we're not on the specialist register. We are on the Family Physician Register. The Singapore Medical Council on its website has this to say: the Register of Family Physicians was formally established in July 2011, and the register serves to recognize medical practitioners with the relevant qualifications and set the standards of practice for family medicine. Interested doctors may apply with the Family Physicians Accreditation Board and register with the SMC. Now the SMC is actually, this family register is actually quite powerful because, as you can see in this newspaper report, only doctors that are not on this register will be barred from including the title family physician to their names. You'll be breaking the law if you use the term family physician. And a clinic name cannot use the word family either. So you cannot call yourself Tan Family Clinic if you're not on this register. So I was very bold, way back 18 years ago, I actually used the term family medicine clinic. And I tested the ministry and asked, can I use the term family medicine clinic? They said, well, of course, there's nothing to define family medicine, you can use it. So I slipped it in, and I was the first to have the term family medicine clinic. Unregistered doctors who break these rules after July the 1st will be penalized under the Medical Registration Act. I won't go into the details. I am a medical legal consultant. The penalties can be quite hefty, and you don't want to fool around with this. The paper then reported that most doctors generally support the idea, but some expressed concern over the use, actually the exclusive use of the term family physician. Prof. Lee of the college, as president of the college, said 2 years ago, in a way, I quote from Prof. Lee, quote, in a way, the formation of the Family Physician Register is a validation of the good work that family doctors have done in Singapore and recognition of the expert skills and knowledge that a well-trained family doctor possesses. It also signifies the ministry's commitment to support the development of family medicine as a generalist discipline that is on equal footing with all the other specialist disciplines. And this one's taken from the paper Future of Family Medicine. I won't go through it, you can read it for yourself. The aims of the register is actually to raise the overall standard of family medicine practice in Singapore. And formal training in family medicine will be a prerequisite for entering the register. So no training, no register. This is very similar to the VR, the Vocational Register of Australia. System changes, because it's going to touch on some practical things. Training of has been already covered by Prof. Lee, so I won't cover it. Primary healthcare in Singapore is actually divided into two parts, as Prof. Lee has mentioned. The government polyclinics actually see 20% of the total cases, but 80% of chronic diseases cases. However, on the other side of the coin, private GP clinics sees 80% of cases, but 20% of chronic disease cases. Now, what does that actually imply in numbers? Actually, you can see that there are only 400 doctors in 18 public polyclinics, while there are 2,000, 6 times, 2,400 doctors, and Prof. Lee's slides actually is not 1,300, it's 2,000 private clinics. So 2,000 versus about 10 times, 2,400 versus 40, 6 times. 6 times the number of doctors seeing only 20% of cases. This is illogical. It is a perversion of the system. The patient has been incentivized to go and see the big doctor in a big hospital and sees him for a cheaper price than what we in the market forces can sustain. For a long time, the Ministry of Health refused to recognize this. It was like a pink elephant in a living room. Nobody wants to talk about it. But finally, the minister, after a few changes of ministers, they have begun to recognize that you can't keep building more and more polyclinics and squeeze more and more nurses and doctors and all in there, while you have about 6 times as many doctors there's out there. So they decided that there must be a change. This slide is another one, which I think most of us will know. Family doctors tend to see about 2/3 of all chronic diseases. Internists sees about 1/3. Pediatrics don't see many except for the asthmas, and the other generalists sees a smattering of cases. So there's a new concept that has been developed. It's called right sighting. I checked the dictionary. Actually, there's no word called sighting. It's another Singlish word. The word is actually right sitting. To place the patient at the right place. And what do we mean by that? It's a new concept. It's probably a Singapore concept. Actually, it means that 1, severely ill cases are seen in the hospital, severely acute cases, while 2, chronic stable patients are seen in family clinics, in the community where they should be seen. And this is one of the most important strategies that's about to take place, that has already been underway in Singapore. But again, like Prof. Lee says, we find resistance whenever a good idea is being banded because nobody wants to see change. There's always groups that lobbied it, and there's like in the book, Who Moved My Cheese? You get very upset that your cheese has been moved. So right sighting, we can see there's an imbalance. So private clinics should see more chronic cases. A scheme called CHAS, Community Health Assist Scheme, has been started to allow subsidized patients to see private doctors. And the patient can withdraw from MediSave account to pay for the treatment of chronic diseases per year. At the moment, it's too little, it's about $400. Now, the effect is to move more chronic cases to private doctors and to even out the imbalance, and also it helps to keep the skills of the private doctors in the management of chronic diseases. Hospitals have long been overloaded with chronic diseases, and the program in Singapore General Hospital is called DOT, or Deliver on Target, which works with the specialist department to look for the stable cases to be transferred to family physicians. These are some of the newspaper cuttings in Chinese, in Mandarin, and as well as English. It says here, I read to you, more GPs taking care of chronic patients. GPs step in to help chronically ill. Pilot scheme helps diabetic patients to get better. And I'm sorry, I can't read Chinese. Okay, the DOT program has been started in SGH way back in 2007 with diabetes, followed by ischemic heart disease, hypertension, hyperlipidemia, followed by asthma about 2 years later, and renal diseases, congestive cardiac failure, and this year for orthopedics. So there's about 1, 2, 3, 4, 5, 6 conditions. There are more to go. This is a very new slide. In fact, they weren't too keen to give it to me because they're going to present this in Melbourne in August. So they asked me to please take good care of this slide and present it well. They have done a study, and because the question here is outcome. Yeah, you may save cost and you may make it more accessible, but is it better for the patient and his or her illnesses? Because if you're going to mess it up and make the patient worse, then it's a bad system. Maybe cheap, but it's not good. Maybe fast, it's not good. Like I said, the triad. You can have 1 or 2, but not 3. But the study has been done, and actually it shows the one in blue is GP, the private GP, and the one in red is the hospital's specialist outpatient clinic. And as for blood pressure systolic, which is the first one over here, you can see there's not much of a difference between systolic BP, neither there is for diastolic BP. For low density lipoprotein, no difference. HbA1c, no difference. So this is going to be quite a landmark slide. Probably the author is going to publish this paper. It's not my work. I don't claim credit for this, but I think the credit should go to the GPs who are managing the patients so well. So this little slide shows an illustration of the whole idea. Patients like to see big doctors, the big doctor in a big clinic, in Hokkien, they say "tua lo kun," and the whole idea is to move the patient flow down to the primary healthcare providers and community services. There's no need to work with the gatekeepers of the specialist clinic, and moving forward, we'll be trying to extend right siding program to other health clinics in the hospital. So with that, I wish you all a happy World Family Doctors Day, and I thank you for your attention.
Thank you.